Welcome everyone to the TechRRT Capacity Strengthening webinar series, Programming for the Non-Breastfed Infant, Protecting, Promoting and Supporting Infant Feeding in Emergencies for All Children. Today we have our third webinar in the series on safer breast milk substitute programming. It's like an exciting webinar today. I'll just take a couple of minutes right now to introduce the day in our session. Okay. Today's webinar, first we'll have a brief introduction, then I'll introduce you to the TechRRT, then we'll have an overview of the webinar series, that's the three in the series, and then we will go to our main presentation. First we'll have Breastmilk Substitute Use in Humanitarian Settings. That will be presented by Brooke Bauer. That will be followed by two case studies. The first one will be from Haiti with Victoria Sibson, and the second one will be from Jordan with Sura Al.Samman. After that, we will wrap up with questions and discussions from Alessandro Iellamo. We call him Alex. So when you hear me saying Alex, you know who we're talking about. Finally, at the end, I will share with you a webinar evaluation series. Right now, Geraldine Belloch, who is filling in for the deputy program director for TechRRT, will share that with you in the chat box. If you can open that now on your in a web browser so that you've got it sitting there for when you finish the webinar and you can quickly just run and do the evaluation, that would be much appreciated. Okay. Throughout the session today, feel free to type questions in the chat box during the presentations. These will be gathered at the end, and Alessandro will pick out we'll compile them, pick out ones that are similar to be able to ask questions to cover what's being asked. If you don't have your question answered during the webinar today, don't worry, we will find ways to answer your questions, okay? Before I move on, I should introduce myself. My name is Andy Kendall. I'm the TechRRT Program Director. Okay, now, just to briefly tell you what is the TechRRT, just so that you understand why we're interested in presenting webinar series. We are a technical rapid response mechanism that deploys advisors to support improved nutrition programming. We do that by deploying advisors, by doing to emergencies or contexts that are relevant to emergencies, so can be prepared for preparedness as well, remote support in the same settings, and also capacity strengthening, for example, through these webinar series. We are a consortium that started out in August of 2015, so we've just completed 4 years of operations. We're led by International Medical Corps with Action Against Hunger and Save the Children as our very close consortium partners. We have funding from 3 main donors at the moment. Our original and biggest donor still is USAID through FDA. We have Irish Aid and CEDA who have come on board to complement the funds from USAID, which is very much appreciated from all the 3. We work in close collaboration with the Global Nutrition Cluster and UNICEF, and we are within the new Global Technical Assistance Mechanism for Nutrition. The Global Technical Assistance Mechanism for Nutrition, if you haven't heard about it, it's a newly launched, or we're actually launching, I should say, overarching body with the objective to provide a predictable, flexible, systematic, and effective approach to respond to nutrition technical gaps and meet the nutrition needs and rights of vulnerable populations, including children, adolescents, and women in humanitarian contexts. Okay, enough about the TechRRT. Now we go on to the webinar series. The aim of the series is really just to increase knowledge and understanding of safer options for management of non-breastfed infants in order for programming to become more systematic within emergencies. I think as we've got lots of practitioners out there on the call today, I'm sure most of us have come across cases of non-breastfed infants that are really at the point of at a very critical in a critical status. And we come across them and we realize we don't have anything in place to handle them. And therefore, this is the point of this webinar series, is to try to make our response more systematic and less ad hoc. The objectives of the webinar in general is to present the current guidance, the evidence and recommendations around relactation, wet nursing, and safer breast milk substitute programming, to highlight successes for specific country and organizational practices, to identify challenges and opportunities that should be considered in our IYCF-E programming, and to provide a platform to identify issues, concerns, and gaps that we really need to address, whether it's opening up new discussions around specific areas that are problematic, to try to figure out what is a way to get past these obstacles. You've probably seen this. This is about the whole series, the initial invitation for the whole series. As you see today, we're on our the third and last one of the series. The first one we had on the 26th of September on relactation. The second one was last Thursday, the 3rd of October, on shared or wet nursing. And today's is on safer breast milk substitute programming. What I would like to highlight is this webinar series has been a collaboration of lots of organizations. The three that have worked very, very closely together to make it possible have been the TechRRT, the Save the Children, and the Infant Feeding and Emergencies Core Group, without which we would never have been able to reach the stage we are now of actually presenting these webinars to you. So thank you to my close colleagues. Okay, so today's presenters, the first one we have is going to be Brooke Bauer. She has an MPH. She is actually she's just joining the TechRRT now as our permanent IYCF-E advisor. She's also the founder of the Nutrition Project International. Brooke, can I ask you to jump in for a second to just say a few words about yourself, please?
Sure. Hello, everyone. I'm Brooke. As Andy mentioned, just started with TechRRT as the IYCF-E advisor. Previously was working with Nuture Project International, which I founded in 2016. I'm calling in from Abu Dhabi, which is my home base, and I'm based mainly around the Middle East and South Asia.
Wonderful. Thank you, Brooke. Our second presenter, Victoria Sibson. She is joining us. She's currently the Deputy Director for First Steps Nutrition Trust. She will be presenting the first case study on Haiti. Victoria, can I pass over to you to say a couple of words about yourself, please?
Hi everyone, great to be able to share my experiences with you today. I'm a public health nutritionist. I spent 6 years working for Save the Children. I have a background focused on humanitarian nutrition, and I now work for a UK-based organisation called First Steps Nutrition Trust.
Wonderful, thank you, Victoria. Finally, our third presenter today will be Sura Al.Samman. She is currently a nutrition consultant. She was formerly from Save the Children, Jordan, and her case study today will be presented on Jordan with Syrian refugees. Sura, can I ask you to jump in now for a second, please?
Hi, hello everyone. My name is Sura Al.Samman, and I was the Health and Nutrition Manager at Save the Children Jordan between 2012 and 2017. Glad to be here today with you to share with you our experience in supporting non-breastfed infants and managing BMS during that period.
Wonderful. Thank you very much, Sura. You'll obviously be hearing from all three of our presenters over the day. Now, just as we go into the first presentation by Brooke Bauer, I just want to remind you a couple of small things. One, make sure that you mute yourself. If you come off mute or you end up showing your video, we will quickly take care of that and put you back on mute, or shut off your video so that it doesn't disrupt everyone else. But please try to keep yourself on mute. Also, to remind you, if you have any questions or comments, please, during the presentations, type them into the chat box So our facilitator for the questions and discussion session can start working through those and be ready at the end to be able to, for Alex to ask you to maybe present your question potentially. Okay, over to you, Brooke. Looking forward to your presentation.
Okay, thanks, Andy. So this will be covering, as Andy mentioned, BMS use in humanitarian settings. Let's change the slide. We're going to talk about why and when, and we'll go over the overview of the guidance. We'll discuss minimizing the risks, guidance for programs, and toolkits and resources so that those are available after the presentation. Next slide. It's important to remember that feeding a breast milk substitute to a minority of children should not interfere with protecting and promoting breastfeeding for the majority. So anything that is done with BMS use must be accompanied by a complete program, multi-sectoral programming for IYCF. Next slide. Next slide, thanks. As Andy mentioned, and the reason for this, this series is because non-breastfed infants, they're an incredibly high-risk group. They require special attention, and their vulnerability increases immensely during emergencies. So it requires special focus and attention. We also have to remember that BMS is always a last resort. There's certain circumstances when it may be appropriate. So for infants from 0 to 6 months for whom lactation or wet nursing is not an option, we're talking about possibly orphaned or abandoned infants who were never breastfed. We can use BMS during relactation as a woman, a mother is building up her breast milk supply to transition off of BMS. Or if a survivor of sexual gender-based violence is simply unable to breastfeed, so if a child is born as a result of a rape, and when it's medically indicated, and we'll go through that in a second. Next slide. So whenever the discontinuation of breastfeeding is considered, the benefits of breastfeeding should be weighed against the risk posed by the presence of the specific condition listed. And we'll go through these conditions in just a second. Next slide. So we always have to weigh the risks and consider if it's FASS. So if it's acceptable, does the mother perceive a problem in replacement feeding? We're thinking, you can move, yep. So we're thinking potential problems that may be cultural, social, or due to fear of stigma and discrimination. We want it to be feasible. We have to make sure it's feasible. If the mother or family has adequate time, knowledge, skills, resources, and support to correctly mix the formula or milk and feed the infant up to 12 times in 24 hours. We have to ensure that it's affordable, that the family or the mother, possibly with community or health system support, can pay the cost of replacement feeding without harming the health and nutrition status of the family. We want to make sure that it's a sustainable and affordable process. Sustainable availability of a continuous supply of all tools. So we're not talking just the formula itself, and ingredients needed for safe replacement feeding for up to 1 year of age or longer. And we have to make sure that it's safe. So replacement foods are correctly and hygienically prepared and stored and fed preferably by a cup. So in order to assess if BMS is appropriate in particular circumstances, we have to understand these conditions and through a full assessment, understand this availability with the family. So there's some reasons for temporary or permanent BMS use for infants. These are acceptable medical reasons for BMS use substitutes by the WHO. Galactosemia is breastfeeding is contraindicated. A specialized infant formula is required, as is in maple syrup urine disease. PKU as well, although some breastfeeding is possible with close support and monitoring. And a temporary supplementation might be required for infants who have low birth weight or who are very preterm or who have hypoglycemia. Breastfeeding is obviously recommended in those situations, but BMS use may be indicated as well in addition. Next slide. Maternal reasons for temporary BMS use. There may be considerations in these conditions. For example, HSV1, hepatitis B and C, tuberculosis, maternal medications, substance use, or severe illness. Breastfeeding is always can be the primary feeding method for all of these. However, there's conditions that may require consideration for temporary use of BMS, such as open lesions on the breast in a herpes outbreak, and so on, with special consideration to certain medications, etc. Next slide. There may be maternal reasons for possible permanent BMS use, for example, with HIV. However, breastfeeding is the primary feeding method unless replacement feeding is AFASS. Same with Ebola in certain situations. If the infant is separated from the mother, as wet nursing and donor milk is not recommended. However, there are situations with Ebola that breastfeeding is possible as well. Next slide. So using BMS in a humanitarian context, it requires this response to be context specific and highly coordinated with skilled support to ensure minimizing the risk. It requires a multi-sectoral response that's closely coordinated with all agencies in nutrition and health, as well as with the government and so on. Next slide. There are international guidance and standards that we can look on when creating programs to ensure that we're working within the best possible standards. Guiding principles for feeding infants and young children during emergencies, WHO 2004. Principle number 3 covers breast milk substitutes. The International Code of Marketing of Breast Milk Substitutes, WHO 1981, it provides information on appropriate infant feeding and the regulation of the marketing of breast milk substitutes, bottles, and teats. Infant and young child feeding in emergencies operational guidance. For infants who aren't breastfed, you can look at 5.10 to 19 and section 6, minimizing the risks of artificial feeding. This is a field guide example, as is the SPHERE standards, the Humanitarian Charter and Minimum Standards in Humanitarian Response. They cover infant and young child feeding and standard 4, including BMS use. And another good document is the Infant and Young Child Feeding Practices SOPs for the handling of BMS in refugee situations for children 0 to 23 months, which is UNHCR and ENN. It provides guidance on how staff and UNHCR partners can manage artificial feeding in refugee contexts. Next slide. All of these documents cover very similar guidance. With respect to policy and coordination, we want any BMS use, messages regarding BMS, coordination regarding BMS to be strictly controlled. So we want joint statements, communications with the media so that we're not calling for BMS or donations to come into the country after the emergency. If breast milk substitutes are the only acceptable options, it's required that it includes an essential package of support, for example, cooking and feeding equipment, water, wash support, and access to healthcare services. And ensuring a strict targeting and use, including procurement, management, and distribution of BMS. It must be based on needs and risk, on the needs and risks assessments, data analysis, and technical guidance. Okay. So with regards to technical knowledge, persons responsible for BMS distribution must be informed and equipped to ensure minimization of risk for preparation and use. It has to come from a place of informed technical response. It requires individual assessments, counseling, and follow-up by a skilled provider. With regards to bottles and teats, there's no do not use feeding bottles. They should not be distributed. They should not be encouraged. They are too hard to clean, and they are too difficult to use, and cup feeding should be encouraged instead. With regards to targeted distribution, infant formula and other BMS substitutes in general, they are not included in general or blanket food distributions. If they are, it's likely that they will be used even by breastfeeding mothers for a number of reasons. So they're not to be included in any general distributions. Health facilities and health professionals should not ever have a role in promoting breast milk substitutes. And free samples should not be provided to pregnant women, new mothers, or families. This should be actively avoided. With regards to distribution, it's very important that we're not only looking at BMS, we're looking at milk powder and milk in general, so as we do not undermine breastfeeding. So dried milk powder should never be distributed as part of general ration program. That's including milk intended to be mixed with tea. The risk that it's used as a breast milk substitute is high in that situation. Bottles and teats should never be accepted or distributed. Where UHT, so long life milk, is distributed, it should be clearly labeled with an appropriate health message in the language that can be understood. So to minimize the risk of breastfeeding infants receiving BMS when creating a BMS program, we have to consider that BMS is a high commodity product. We do not want to encourage the selling of BMS, which is very common. So we don't want to give out large packages of infant formula at one time. We want to open the tins when we're distributing them to discourage the selling of them. We also want the tins to be numbered and labeled, and empty tins to be brought back in return for a full tin. That allows, by bringing those tins back, it allows for you to also follow up with the family as well. We want to avoid breastfeeding mothers being involved in the program or being enticed to be involved in the program. So we want to locate any BMS programming away from any IYCF-E sites. We don't want to discuss programming in front of the general public. We want to ensure that any infant formula distribution or storage is out of sight of general view. We want to ensure appropriate targeting as well. So we want to make sure that the targeting criteria is clear to the staff. We need it written down in order so that staff can show this to people who may be requesting BMS but do not meet the targeting criteria. We also want to encourage home visits, get to know the families, and so on to make sure that we're targeting the appropriate population. Next slide. So program basics, provision for, if we begin to distribute BMS, we have to distribute it for as long as the infant requires. So until breastfeeding is reestablished, or at least until 6 months of age, depending on the context, at least until 6 months, sometimes longer. We want to ensure follow-up at least twice a month, and we want to ensure that we're tracing defaulters, those that aren't coming back into the program, and we want to work closely with the health sector or health cluster to continue to monitor diarrhea through surveillance mechanisms to ensure that we're not creating and causing more harm with that. Next slide. It's required that all staff are trained. including staff outside of health and nutrition in the organization that is working with the BMS. They should at least be sensitized in IYCF-E. Health and nutrition staff that are specifically working with IYCF-E and with the BMS programming, they must have specific 5-day trainings with other recommendations, days devoted to BMS use in emergencies for decision makers and BMS focal points. It's important that the staff is technically sound and confident in the programming. Clear guidelines and policy documents, as I mentioned, should be in place, not only within the organization distributing BMS, but in coordination with the health and nutrition sectors. So clear guidelines with regards to donations, procurement, distribution, and monitoring and evaluation. And they must be understood through all partners. Next slide. Thanks, Andy. So very basic, powdered infant formula versus ready-to-use infant formula, 2 different things. Powdered infant formula is generally used more often. It's not sterile. It requires reconstitution with water that's been heated to at least 70 degrees Celsius. So it requires more utensils, more specific guidance and it requires more materials to be able to reconstitute that to feed. RUIF, it's a stale product until it's opened. It does not require reconstitution. Appropriate use, careful storage, and hygiene of feeding utensils remains essential to minimize the risks. However, RUIF is more expensive and bulky to transport and store. It's also slightly more difficult to procure. So generally, PIF is used more often. Thinking of the 6-month formula needs for infants less than 6 months of age, we're talking about 750 mils a day, so 135 liters for 6 months for RUIF, and for PIF, 116 grams a day, or 21 kg for 6 months. Next slide. Supplies should have a 6-month shelf life from point of delivery. We have to ensure that if we are distributing BMS, that we're distributing it appropriately. One thing to consider if you have programs using F100 or F75, if you have malnutrition in your context, that F75 and F100, they're not appropriate BMS in non-malnourished infants. The introduction of therapeutic milk in tins in 2017 can possibly cause confusion with infant formula in settings where BMS is used. So education is required. As you can see on the right, that's the new tin that was switched over from the previous sachets on the left. So one of the reasons for the education is if we're discouraging breastfeeding families, or we're discouraging in the context not to use powdered infant formula. However, if a child does become malnourished and goes into a program, a CMAM program or a stabilization center, and they see the use of something that looks very similar to what is powdered infant formula that we are discouraging, that can be very confusing, and so requires specific education in that context, or at least specific messaging. Next slide. So you can see the similarities with this tin here. So any BMS distribution that is done in the context, it must have labels in accordance with the code, with the BMS code of conduct. It has to be discreet and away from the public. Any counseling and messaging should be one-to-one and never in a group. There should never be a circumstance where we are teaching in a group anything about how to use BMS or the use of BMS in the context. Tins should be hidden away from the public view when in storage. This is an example from South Africa of a infant formula tin that is compliant with those considerations. Next slide. These are the resources and tools. the UNHCR infant and young child feeding practices SOPs, which I mentioned earlier, including the SOPs in the first link and the annex in the second, which have quite a lot of resources and tools available through that annex. The WHO guiding principles on infant and young child feeding in emergencies. Save the Children IYCF-E toolkit is a great place to look when beginning any IYCF-E programming, but also when considering BMS use in emergencies. The WHO acceptable medical reasons for breast milk substitutes, HIV and infant feeding in emergencies link, as well as the interim guidance for nutritional care for children and adults with Ebola virus, and WHO guidelines for BMS preparation. When we are working with families who are using BMS, we need to ensure that we know how to, first off, that our staff and we know how to prepare appropriately the formula, but that we're teaching the families in that one-to-one counseling how to prepare it properly, and that we're going to their house or their shelter to follow up and ensure that they're doing it. So going to the house, when we're doing our home visits, going to the house and asking them, for example, just as we would ask a breastfeeding mother, do you want to, if you're assessing or providing an assessment to breastfeed in front of you, to ask the family to prepare the BMS in front of you in the home visit is a good way to ensure that we're minimizing risks. And that is it.
Wonderful. Thank you very much, Brooke. I want to, before we go on, I would like Alessandro to jump in to mention something about WHO guidance. Alex?
Yeah, no, and I think Brooke, sorry, Brooke, I just wanted, I think it's very important to say that the 2007 guidance that Brooke has been used and is extremely relevant, but I guess it's very important also to say that the HIV section has been updated regularly in 2010, 2016, so, and Brooke mentioned the two relevant guidances to be used for HIV, so use the 2007, but disregard the HIV section within that 2007 and use the HIV guidance of WHO of 2016-2017. Just that. Over.
Wonderful. Okay. Thank you so much, Brooke, for that comprehensive presentation, and Alex for that clarification at the end. I'm sure we've got lots of food for thought from that, and I would like to keep encouraging people to write questions in the chat box as we go. Now we're going to go on to our first case study. So I'm going to hand over to Victoria Sibson on the HAITI case study. Over to you, Vicky.
Thank you. As I said earlier, I worked for Save the Children for 6 years. I was the Humanitarian Nutrition Advisor from 2007 to 2010, and I was deployed to Haiti for the earthquake response in 2010, along with lots of other people. So I had a specific role in that response, and that was managing the infant formula for the IYCF-E component of the response, and that's what I'm going to focus on in this presentation. So the Haiti earthquake was nearly a decade ago now. It happened on the 12th of January 2010. It was a massive earthquake that measured 7.3 on the Richter scale, and the epicenter was close to the capital, Port-au-Prince. 3 million people were affected, which was 30% of the whole population of Haiti, and half of these people were children. Half of these people were displaced by the destruction. You can see a picture that I took that captures that there. There were a huge, there were a huge number of people. Can you go back, please? Killed, 300,000, and 300,000 people injured. there were very poor estimates of the numbers of women, children, and infants affected. So that made planning quite difficult. Next slide, please. Before the emergency, infant and young child feeding practices in Haiti were poor, and this was particularly so in the capital, Port-au-Prince. So nationally, breastfeeding initiation within an hour was 44%, and exclusive breastfeeding was 41%, but this was quite a lot lower in Port-au-Prince at 21.7%. We didn't have any data on the number of infants not breastfeeding or being formula dependent, despite it being a culture in which formula was being used before the emergency. So mixed feeding, where mothers were giving breast milk alongside other replacement feeds such as diluted, sweetened, condensed milk, was really common. Two other important features of the context. One was that Haiti had the highest HIV prevalence in the Caribbean, at 3.8%. And the other was that a fifth of infants and children were classified as orphaned and vulnerable children even prior to the earthquake. So these factors further complicated the design and implementation of the effective response to protect, promote, and support optimal infant and young child feeding practices. Next slide, please. In terms of the IYCF-E response, the Haitian Ministry of Health and Public Health and UNICEF coordinated the nutrition cluster jointly, and within that cluster there was an IFE working group. Save the Children and quite a lot of other NGOs implemented a baby tent response, and there's a picture there on the right of one of Save the Children's baby tents. And these were safe spaces to support breastfeeding and also safe formula feeding using the ready-to-use infant formula and necessary supplies to do that. And for babies meeting strict eligibility criteria, there were 7 categories, and the most obvious being orphaned or abandoned by the mother. So health and nutrition staff working in the baby tents were given technical training on breastfeeding and artificial feeding by skilled experts. And this training included maintaining or re-establishing breastfeeding, relactation temporarily using the RUIF, minimizing the risks of using the formula among those meeting the criteria and being given it, and also encouraging and supporting wet nursing where that was possible. Save the Children had a role within the cluster to store and supply the ready-to-use infant formula to nutrition cluster partners after training. That was what I was specifically looking at. And the RUIF was a commercial product procured by one of the donors and made generic through a code-compliant label in Creole, which is the local language. Next slide, please. So baby tents were the hubs for the intervention delivery. And outside of those tents, there were connected community activities, including mother-to-mother support groups and active case finding to try and find the babies that would meet the criteria for breastfeeding support or support for artificial feeding. There was a really good effort at cross-sectoral integration, realizing the importance of that. So with health and nutrition, with logistics, with food security and livelihoods, and also child protection. And there's a nice article published in Field Exchange 41 by Lucia Pantella, where you can read more about that and the lessons learned. The only existing national guidelines and protocols that we could draw on for the response were CMAM and also HIV and infant feeding. So we designed the response, the nutrition community, informed by the operational guidance on IFE, which is a version that precedes the current version. Next slide, please. So the results and successes have have been documented and published in 2 papers, one in the Bulletin of the World Health Organization and one in PLOS ONE. I've put the references down there so you can look them up later. But here's some of the figures of what was achieved. So between February 2010 and June 2012, 193 baby tents were set up. There were over 180,000 mother and infant pairs enrolled, and over 52,000 pregnant women registered in the baby tent program. So it was massive, a massive response, a massive program. Of infants younger than 6 months of age, 70% were reported to be exclusively breastfed, and 10% who were mixed feeders became exclusively breastfed with the support provided through the program. 13.5% of the enrolled infants were given RUIF, so the rest were not eligible and were given support for breastfeeding. But interestingly, of these, only 41% were orphans and abandoned infants. So 59% fell into other categories, for example, being babies of HIV positive women who were using formula before, or being fully formula fed before. But actually, if you read the papers there that I've put the references for, there was a lot of incorrect admissions. It's a very difficult program to set up and run. So probably some definitely some babies who were being given formula wouldn't have met the eligibility criteria, unfortunately. Next slide, please. In terms of key challenges in implementing this response, it was absolutely massive, which meant that there was a lack of time and a lack of staff to do what was needed to be done. There was a need for more Francophone and Creole speakers to facilitate the work. We had to develop the program model and the tools to run the program there and then in the middle of the emergency, which was difficult. And it's one of the reasons why we ended up with poor data to assess the quality and impact. Because, for example, we didn't have M&E tools available at the beginning. The ready-to-use infant formula was a completely new product to learn how to use in real time, and it was logistically really demanding. So that's a picture of their warehouse, and you can see it's extremely bulky. It means it's extremely heavy, just really hard to move around. So that was extremely challenging. And then another challenge, a technical challenge, was a discrepancy between the current national and international policy on HIV and infant feeding, which made programming quite difficult. Next slide, please. So in terms of lessons learned, and these come from that time, nearly 10 years on, so it would be interesting to get reflections on whether these are still relevant. There was a need to improve methods for estimating affected populations and therefore necessary supplies such as formula. In fact, we had too much formula because there was an overestimate of requirements, and that posed problems in terms of what to do with it. There was a need for model program protocols and tools, so like generic pre-existing protocols and tools which the program could be designed around, including program performance monitoring tools. The response showed that there was a need for robust evaluations of responses like this, including looking at longer term impacts of use of formula. And then lastly, as I highlighted, the ready-to-use infant formula does have advantages. It did have advantages, but also disadvantages, quite significant ones. So it's important, it was important then, and I'm not sure what's been done since then, but to look at how to minimize the risk of programming using powdered infant formula as a priority instead of thinking that it's always best to use ready-to-use infant formula. And that's it from me for now. Thank you.
Wonderful. Thank you so much for that example, Vicky. It's incredible to see what's possible when there's willingness. The scale that you were able to reach in Haiti is really incredible. And it shows what's possible. Okay, with that, we're going to go on to our next case study. So thank you, Victoria. And now we're going over to Sura Al.Samman with the Jordan case study. Sura, can I hand over to you now, please?
Thank you, Andy. So before I start, I just want to highlight that in addition to managing the IYCF program, Save the Children was actually co-chairing the nutrition working group, initially with UNHCR and then with UNICEF. And many actions taken throughout this response, and specifically the ones related to BMS, to controlling donations, were doable and paid off and were successful because of the very strong position and follow-up that the working group had and the prioritization that it gave to the issue of infant formula. So, with the first slide, what you're seeing here is data camp. Since the beginning of the emergency in Syria, over 650,000 Syrians have crossed borders into Jordan. They were either living in the host community or in refugee camps. 48% of those refugees originated from Daraa. It was the main governorate where refugees were coming from. Others were coming from Homs, from Aleppo, from rural Damascus, and from Damascus. Most refugees have been till now have been in Jordan for 4.6 years on average, and according to UNHCR data, 2% are now back into Syria. 84% of the refugees are living in the host community, and 16% are living in the 3 refugee camps, Zatari, Azraq, and the Emirati Jordanian camp. Zatari is the largest one. It opened in July 2012 and is under the joint administration of Syrian Refugee Affairs Directorate and UNHCR. At some point in 2013, the population in Zatari reached 203,000, but now it's home for around 77,000 refugees. Also, data from UNHCR says that we have 23% females between 18 and 59 years, and 15% children under 5. The percentage that may be the highest is actually the newborns or the new deliveries in Zatari. We had around 80 to 100 new deliveries on weekly basis in Zatari. So that was a high percentage. Next slide, please. What you are seeing here is different data for IYCF practices before the emergency. The first one is for Syria, Family and Health Survey. The second one is for Jordanians, Jordan DHS data 2012. And the third one is the Interagency Nutrition Survey that was done in Zatari in 2014. As you can see, IYCF practices were already poor in Syria, and it was even worse in Jordan. So in Zatari camp in Jordan, there was a high demand for infant formula in the early stages of the crisis, both because of the unsolicited donations that were everywhere in the camp, and the fact that the use of infant formula was very common, and Syrian mothers were really used to mixed feeding. In addition to Syrian mothers dealing with Jordanian doctors who are also used to prescribing infant formula. Next, please. So, with UNHCR coordinating this response, the Nutrition Working Group was established in late 2012. The initial advocacy initiatives involved the development of 2 very key documents. The first one was the guidance note on appropriate IYCF practices in the current refugee emergency in Jordan. And the second one was the SOPs on donations, distribution, and procurement of infant formula feeding equipment in the current refugee emergency in Jordan. It was really crucial to share those documents with everyone working in this response because the concept of controlling BMS was relatively new for everyone here. Save the Children entered the Atari camp also in late 2012. The program, the IYCF program, consisted of like 3 locations. We had education sessions in all locations, and in coordination with other partners, we had sessions in community centers, in health facilities, in anywhere you could think of mothers gathering. We had education sessions held there. We also had individual counseling sessions. The program started with 4 counselors doing home visits, but gradually that increased to 12 counselors. The home visits component and the individual counseling component played a key role. The follow-up, the fact that each mother comes requesting infant formula is immediately followed up, that also made a huge role in reducing the request for BMS. We had a bottle cup amnesty program where mothers would exchange their feeding bottles with safer, easier to clean and easier to use cups. Personally, I thought that this would be really challenging, but mothers were surprisingly excited about it. And by the end of the 3rd year, we had more than 5,000 bottles sent to recycling, where mothers have actually exchanged them with feeding cups. The last component of the program was monitoring of infant formula prescription. So Save the Children was not involved in distributing or procurement of the formula, but we were involved in monitoring how the formula is prescribed and how it's distributed. When we first entered Zatari, formula was available in the market, and field hospitals were distributing that to all new deliveries within the baby kits, along with bottles and teats. So, and the fact that controlling BMS is a new concept, this triggered a very negative reaction for refugees. And most of them argued that BMS should actually be part of the ration distributed to each family with a child under 2 years old. So, the 2 documents that were shared highlighted the key actions that need to be taken in order to promote and to protect breastfeeding and ensure that infants who need infant formula, that the needs of those infants are met. It was agreed that one agency only, which is UNHCR, should be responsible for procuring the formula. Any unsolicited donations of infant formula or bottles and teats should be reported either to UNHCR or Save the Children Jordan. Partners were informed that BMS is available for children under 12 months, but only via prescription from a health clinic after assessment is completed for both the mother and the child. You would think that convincing mothers of the criteria is the most difficult part in this, but actually it wasn't. Each step, starting from agreeing to have the prescription in a health facilities, partners refused having to do anything with this because of the negative reaction of the refugees. The partners were really intimidated by the anger and the feedback that we got. So it was really difficult to agree with the health facility to do the assessment and the prescription. It was really difficult to agree with another partner to do the distribution or to have the stock there for infant formula. So for the prescription itself, we agreed that it needs to be done only in one health facility. There shouldn't be more than one health facility doing that. It shouldn't be available in more than one location. An IYCF counselor was always available with the midwife during the prescription sessions. Counseling for mothers who thought that their milk is not enough also was always available, and mothers would be seen immediately after they leave the clinic. Another counselor responsible for a specific district would be visiting that mother. The prescription process itself included physical examination. So the mother would actually, the midwife, would actually examine the mother if she had milk supply or not. We would look at the medical reasons for using BMS. And on a later stage, we had weight monitoring being part of this assessments. As I mentioned, mothers would receive a follow-up visit from the counselor responsible for their district immediately after they leave the clinic, or on the second day after they receive the formula, if they were eligible for receiving an infant formula. The counselor would explain safe preparation and check if there is a need to refer to WASH, hygiene promotion, or NFIs. We didn't have a BMS kit within this program component because the WASH situation was generally acceptable in the camp, but when counselors would do home visits and follow-ups, they would see the need, if there is a need to refer to hygiene promotion, or the need to provide the mother with further items. The distribution was also agreed to be in one site. We had an IYCF-E Syrian community mobilizer available on the day of the distribution, and she would be advising mothers on the safe preparation before the counselor visits the mother. She would be monitoring the distribution, and even with those precautions, we had some occasionally we had some mothers selling the formula. So it was agreed then to open the tin and ask mothers, as Brooke mentioned in her presentation, and ask mothers to return the empty ones. Gradually, with time, we had a simple database developed where we had the name and age of all infants of all mothers coming requesting infant formula, ration card numbers, contact details, date of visits and follow-ups, reasons for prescribing the formula, and possibility of relactation. Just an example I want to give about the numbers we've seen. Between January 2017 and June 2017, we have seen 588 mothers requesting infant formula. Only 114 mothers were eligible to receive the formula. 10% of that number was because the mother was actually absent, and 30% of that number, of the 114, where the baby was not gaining enough weight, and 30% were discharged after 2 months after we've worked on relactation and the mother was fully breastfeeding the infant. Also, it's worth mentioning that by the time the third interagency nutrition survey was conducted in Zaatari, that was 2016, 2 years after the one I've showed you the data for, the proportion of children 0 to 23 months of age who received infant formula was 3.7% only. So, when we are talking about the challenges in implementing the activities for this one, it was the uncontrolled donations of BMS. Field hospitals were always bringing donations in, and it was really difficult to convince them to hand it into UNHCR or to go through the official procedure that we agreed upon. At some point, we had to move the distribution site to one field hospital, of course, after checking that the infant formula is according to the correct expiry dates and is with the correct language, but we actually had to move the distribution site to that field hospital and use the stock they brought in to make sure that this is controlled and this won't be distributed randomly. Another challenge was the lack of monitoring and enforcement of marketing regulations for BMS in Jordan. So, although this was controlled in the camp, but it was not in the host community. And many mothers who delivered outside the camp, actually 17% of them reported receiving infant formula after delivery in a private hospital. So mothers would be in the camp until delivery, they would go out and they would come back with infant formula. Another challenge was the misconceptions, the cultural beliefs and practices. Using infant formula was the norm in Syria, and the fact that mothers thought it's healthier for babies was a real barrier to exploring relactation afterwards. Another key challenge was the lack of infant feeding knowledge and skills among health providers. Although we had really qualified counselors and we had very close follow-up, but when a mother receives an advice from a doctor saying that your child needs infant formula, it's it would make it even more difficult to argue because the doctor said that. So many misconceptions about health providers and many reports we used to get were related to a new pregnancy. You need to give the mother infant formula. This mother is anemic. You need to give her infant formula. This mother is diabetic. You need to give her infant formula. We had a lot of those misconceptions among health providers working in the camp. Next, please. Lessons learned. As I mentioned in the beginning, leadership. That was the most important point and the key point that made controlling infant formula in Zatari possible. UNHCR played a huge role in convincing and in enforcing the SOPs that we have for infant formula. So if that was not there, if you didn't have someone prioritizing the control of donations, it would be really difficult to move forward. Building capacity and cooperation with health providers and communicating a unified message is also crucial, because at the end of the day, the mother would always listen to the doctor. And this one is something we noticed a bit late, but we're glad we got that. The collaboration with other sectors, training of frontline workers, protection workers, reception workers, people who see the mothers first when they arrive. It's really crucial that they know how the system works. It's really crucial that they have key messages about protecting and promoting breastfeeding. We had many cases where a protection worker or a social worker with a reception person would go out in the middle of the night and buy formula, thinking they are helping those mothers. So orientation sessions, 15 minutes a week, circulating key messages. It's really important that those frontline workers know how the process works and know how important it is to protect and promote breastfeeding, and that the fact that there is a system and there is a support to protect a non-breastfed infant in place.
Wonderful.
Thank
Thank
you.
you for that, Sura. So interesting to hear about the Jordan example, particularly as it is an example in a context that was so different from context that most humanitarian actors were used to. It's the first time we had really experienced a setting that had such high breast milk substitute use before the emergency. Okay, with that, we're a bit behind time now, so I'm going to hand over quickly to Alex, who will facilitate the questions and discussion session. As we mentioned before, the questions will be selected from the chat box by Alex. Please do continue typing questions in the chat box if you have them, and Alex might call on you to jump in, so please be ready.
Yeah. Thanks, Andy, and thanks to the presenter. Just again to the presenter, I'm going to share some of the questions. Please be sharp in answering so that we can get more questions for you to answer, and more information can be shared to our colleagues that are attending the webinar. First, a note, just to clarify, and Andy will repeat it, the materials, the PowerPoint will be shared after you have filled up the survey. Second, so the question, and this is a question for all of you, I believe. This is a very important question about population in move. What do you think? No, how can you support through a safer BMS program population that are moving? And I know Christina shared some of the references that have been developed in relation to that. But what would be your advice? What has been your experience? Over. Anyone that wants to jump in among the three of you, no problem. Go ahead.
I can jump in. This is Brooke. We had a response up in Macedonia, the border of Macedonia, in Greece, where we set up baby tents similar to how they did in Haiti. And it was a very transient population. We used the interim guidance that was shared in the chat. We worked with families really closely with a lot of messaging. We did use our UIF in some circumstances, but it was incredibly difficult. I know that there were a lot of conversations happening at the time about how much to give. There were some concessions made with regards to the amount that was that was given so that where we knew the person was going to next where they could access the next BMS breastmilk substitute. But for us, it was very much counseling and messaging and working closely as much as we could, quite intensively, as the families were going through.
Thanks, Brooke. Any addition, Vicky and Sura?
So for Jordan, it was a very small component for mothers who were coming at night and spending maximum one day in the reception area before they get to the camp. And we used ready-to-use infant formula only for that period. But the easy part about it is that they were very close to the counselors, and we were able to monitor them, and we were able to provide them with what they needed. It was only 24 hours, so I'm not sure how relevant is that.
Okay, thanks, Sura. Vicky, you want to add something about population in move?
Well, in Haiti, that was never discussed as an issue or seen as an issue, but what this question raises for me is whether there was movement that we weren't really aware of, because the evaluation that was done showed a huge a high rate of default from the program. So it could be that actually there was a lot of moving among the population that we weren't really aware about and weren't responding to. So it would be interesting. I know there's others listening here who were involved in the Haiti response, who might have something to say, but maybe that's something that we just wasn't on our radar at the time and should have been. Yeah.
Thanks, Vicky. Now, Vicky, there is a follow-up question. This is specific to the HAITI case, and it's an excellent question, I would say. And our colleague is asking, considering, as you said, also the high rate of BMS users for different reasons. So what has been the steps to try to educate the population in the response you have been supporting?
So one of the activities that was undertaken as a backdrop to the baby tent intervention was a mass media campaign around optimal infant feeding. So with messages around promoting breastfeeding and messages around the risks of using infant formula. So that went on in the background. I think that's one of the relevant activities.
Thanks, Vicky. Now there is another very important question about, and it's still for HAITI, that very specific, maybe also to clarify, about counseling for BMS and breastfeeding in the same area. So are there been any concerns on affecting breastfeeding practices?
As far as I recall, they absolutely were not undertaken in the same area. So I talked about there being a baby tents, but the mums were separated within the service being offered. So in one space, in one tent, the activities would have been with the women who were being supported to breastfeed, and the women who were being supported to use ready-to-use infant formula were being facilitated in other separate spaces.
Okay, excellent clarification. Now a question for all of you. It's very interesting. It's about counseling and the quality of counseling. So during counseling of these women, these mothers that were seeking BMS support, what language has been used to guide them and to help them make the best decision in avoiding judgment, avoiding any wrong counseling words being used? Over.
So, Alex, I can talk a bit about the experience in Jordan. The first thing we noticed is that mothers would actually listen more when we talk about the dangers of infant formula. We would talk a lot about benefits of breastfeeding. It was always there in every session, but talking about the dangers of infant formula, and specifically in this environment, would caught a lot of attention. and would make the mother stop and think about it. The other thing is that going through different IEC material, we worked on more, I would say, more complicated ones, or let's say like telling mothers about the percentage of nutrients that breastfeeding could give to the baby, telling mothers how much breastfeeding covers from the baby needs until he is 2 years old. Those kind of things were really interesting for mothers and made them listen more.
Thanks, Sura. Vicky, Brooke?
This is Brooke. I agree with Sura with regards to the language used. It's discussing the risks is something that we always do as well, and doing it not in a way that we're making it sound like they already are aware of the risks, but highlighting the change in circumstances rather than assuming that it's the same. So highlighting the change in circumstances and providing kind of an overview of what, for example, the wash situation is in the context that they're in, and how that's different than what it was before. So using the language regarding risk in that way seemed to be met with positive responses.
Any addition, Vicky?
I have to say, I really appreciate the question and others' responses, but for Haiti, I don't know what went on at that level. I don't speak Creole. And it was such a huge response. As I was highlighting, because I think this is quite interesting, I had a very specific role to manage the ready-to-use infant formula, working with logistics colleagues. And there were many other people with different roles in the response. So there were these skilled experts that did the training for the health and nutrition staff in the baby tent. So that would have been something I guess they would have been very heavily involved in, but certainly something really vital to get right so that you're supporting women properly.
Thanks, Vicky. Now there is also a very nice, sorry if I'm subjective, but it's a very nice question about, a very pragmatic, and I think is really a real case scenario for all of you and for all of us in the field is, what about your experience in dealing with women that may just don't want to breastfeed, no matter the criteria you set? How do you deal with that? Over.
I'll start, given that no one's jumped in.
Yep.
One challenge that I didn't mention that came out in Haiti very strongly, and I've experienced in other emergency responses, is, and I think it's related to this, and it's really important to appreciate, is when mothers feel very strongly that they cannot do what you're asking them to do. You're telling them that they should be able to exclusively breastfeed, and you explain why they should be able to exclusively breastfeed, because they're eating, they're drinking, their milk supply is not affected by this, that, and the other, and it's all very factual, but they feel that they can't, that it's very important to acknowledge that and find a way to deal with it. And I don't have a response. More, I just wanted to highlight that it's a challenge that I have seen in several emergency responses, and one not to be addressed.
Thanks, Vicky. Any Sura, Brooke?
I agree with Vicky that it's challenging. It's a conversation that happens very often at the field level with regards to BMS use and breastfeeding and maternal choice. And it's a good question. It's a good conversation. I think that ensuring that the counseling and the programming that you are putting into place is meeting the families, the caregivers, and the mothers where they are, so that it doesn't feel like someone is being told what to do, that they do have choice, that you can adapt your programs and making sure that they're adaptable for specific situations is important. There's no one size fits all with any of this. No matter how much we can think that there might be. So I think that meeting the families where they are, really building up counseling skills in the staff and the program workers is really important to make sure that voices are heard and so on.
Thanks, Brooke. Sura, I think you have enough experience around this issue.
Only one comment to add, Alex, regarding the capacity of the counselors. So one of the information we collected when we talked to mother was possible relactation. And that was not only based on the mother physical examination, but also like, is she accepting the idea of relactation or not? And the numbers changed dramatically between 2013 and 2017. I could honestly say that it all goes back to the counseling skills of the counselors and the capacity building you spent on that. So at the beginning, it was always no, like relactation is not an option. But we've seen many mothers agreeing to do that afterwards. So I would put a lot of that onto the counseling skills that the staff had.
Thanks, Sura. Thanks to all of you. And there is a very important question about coordination. I am expanding a bit, sorry, actually, with other sectors, in particular WASH. I know you have mentioned it in your presentation, but maybe you can highlight how this coordination has worked out, in what terms, and the importance of it. Over to the three of you.
So I can start, Alex. We had very strong referral pathways with WASH and hygiene promotion. It all started when we started with an orientation to the staff there, making it very clear to them how important it is, like the dangers of using infant formula and the fact that there are some children we need to provide them with that formula. The counselors would visit the mother, and if there was any issues related to water, related to the utensils she's using, related to the availability of fuel, anything related to the way that affects the safe preparation of BMS, contact info would be sent to hygiene promotion, and they would be visiting her immediately and providing her with whatever they need in that household, whether it was hygiene promotion or also NFIs, non-food items.
Thanks, Sura. Brooke, Vicky?
My experience would be similar to what Sura just described. It requires really strong collaboration between WASH and the nutrition sector programs. There should be, in my opinion, there should be IYCF-E or nutrition people in WASH and in health meetings every time that there is one, to make sure for that collaboration and coordination. There needs to be that strong tie. You need to know the faces of the people running those other programs so that you can easily contact them to ensure that strong referral mechanism and the strong coordination.
Vicky?
In Haiti, I don't recall there being much of an emphasis on coordination with WASH and the link between the IYCF program and WASH above other sectors, for example, food security as an example. And I guess that would be because we were using ready-to-use infant formula. That's all I could think of at the moment. But in the field exchange paper by Lucia Pantella, I remember that there was, I think, a concern around facilities in orphanages, in inverted commas, and there was a push to ensure that the WASH provision was good enough in those children's homes. So yeah, not maybe so much of a emphasis for good or bad reasons, but not so much in Haiti.
Okay, thanks, Vicky. There is an important question from Mia, our colleague. And Mia, would you like to be the one to ask? If not, basically the question is in relation to mothers that insist, in case they insist to receive the support, the BMS. And the question is, yes, if we are supporting the free choice of the mother, so who should then pay for it? Is the organization supposed to pay also, meaning to support the program, to pay for the program, also for those mothers that decides eventually that they want to use the product. Over.
I'll just jump in again because no one else has yet to say I haven't experienced this myself, but when I was reflecting on not diminishing the situation of women who are struggling to believe that they can breastfeed, I wasn't intending to suggest that they be given formula, but more that it's really important to acknowledge that I think, as Sura highlighted, it's the quality of the counselling and probably the time and effort that's put in to support that mother overcome those psychological barriers, if that's what they are, but also to link them to other support that they may require, if it's shelter, housing, food, cash, if that is possible. So somewhat related, but I haven't seen that myself. It might be a reason that you had very many who were probably wrongly enrolled, but I don't know whether that's the case, that they were given it because they insisted.
Thanks, Vicky. Any additional point from Sura and Brooke?
I can jump in. I mean, it's as I mentioned, it's an incredibly it's a difficult but important conversation. When we're talking about choice, we're also talking about different reasons why people ask for formula that's outside of feeding the infant, for example, selling it or using it in other ways. So we have to also, organizations have to also remember that, and it's also very context specific. I know Sura and I have discussed it in the past about families becoming very physically violent or verbally violent in the spaces where BMS is being distributed because it's a very contentious situation at times, especially if there's if you decline to distribute it. So it's incredibly context specific with regards to that.
Thanks, Brooke. Sura, any additional thought? Quick.
No, I don't think I have anything to add.
Right. Sorry. Hello.
No, Alex. Thank you. Nothing to add.
Okay. And I think, as you all mentioned, this is a very important conversation that we keep having in any of the responses. Then clarified, of course, there is also an ethical component that needs to be considered. I have there are a few more questions, and maybe we will have to send the answer later on. But there is just a question I wanted to ask, if I may, and is about, and I think it came quite clearly from the presentation of Vicky, the coherence between what we may face, national guidance versus international recommendations, and in relation to BMS or BMS support. So basically, sometimes we find ourselves working in environments where either the national guidance is silent or it may not be as supportive to those initiatives. So my question would be, what would be your advice? What has been your experience in still ensuring that those children are supported and protected? Over.
Was that question to me, Alex?
To any of you, but you highlighted the point about conflictual guidances in a way.
So, in relation to HIV and infant feeding in Haiti. So, as far as I recall, but it was nearly 10 years ago, the challenge was that I did read it up just before, but I can't remember the ins and outs. The challenge was that the guidance of Haiti was set in 2008 for HIV and infant feeding, and in 2009 WHO had updated its guidance and it hadn't caught up yet. And what it meant, and without going into the detail, what it meant was that us as emergency responders in the international nutrition community coming in to assist with this response could not implement what we thought was right in terms of ensuring that the right children were being encouraged to be breastfed because it wasn't in line with the national policy. And to cut a long story short, we had a painful situation where there was a huge amount of effort to try and quickly work with the Ministry of Health to update their national guidance to align with the international guidance, and until that was achieved, the international guidance could not be implemented. So that was the reality of the situation, and at some point in time the two matched and the protocols were changed.
Thanks, Vicky. Sura or Brooke, any additional idea or based on your experience, for example?
None from my side. It would be this similar to what Vicky just explained is in my experience as well.
Sura.
Same here, nothing to add also, Alex.
Thanks, but unfortunately that's one of the major stumbling blocks we are facing in many responses without mentioning them. But maybe the last last question, really the last, and again we will make sure that if there are unanswered questions, we will reach out to those that have asked this question. There is a recognition that, thanks to this webinar, and maybe we knew it, that there are excellent experiences, and some of them, like the HAITI, has been a few years back, as well as the Jordan experience. So the question is, why did not translate all of these experiences? Didn't translate in something to support programs, in some more guidance, in some more guidelines? Why do you think so? We didn't reach yet that level. To any of you?
I can take.
Go ahead.
I mean, I think it's because the conversation is incredibly difficult. It's one thing to discuss, for example, what I discussed in my presentation with regards to policies and guidance. But as you can see from Sura and Vicky, that translating it into the field, and from the conversations that we're having with regards to maternal choice and declining distribution of BMS, for example, it's incredible to translate into the field, and we see that for example, in Bangladesh or in Mosul, we saw it as well in the transient in Greece. So it's I think that the conversations are avoided very often. That would be my personal opinion, just because they're difficult to have.
One line from Vicky, one line from Sura.
Okay, should I start?
Go ahead.
Okay, so one thing to add on what Brooke said is how different the context is and what is your starting point. So I would say that maybe in the Middle East, having BMS, controlling BMS and IYCF in emergencies is relatively very new. So we would start from a very early stage, from introducing that to health providers, to convincing them. It could be another starting point in another country. So it would really depend on the context and whether that has happened there before or not.
Vicky.
My two observations, I guess, would be, I guess, is that I think maybe donors and political decision makers respond differently to different types of emergencies, and maybe more favorably to natural disasters than to conflicts. So maybe Haiti was better funded, and maybe funding is harder to come by in today's emergencies, which makes it much harder to implement. Responses like IYCF-E, which may still be seen as quite niche, and the BMS component very political. But also a little personal reflection is that lesson learning from emergencies and the documentation. We had two papers that I cited, and then the field exchange article with learning documented from Haiti, which is great. But I think it can be very difficult to take the time to do that, and unless we do that better and give people the time, but also say the emotional and psychological support to be able to do that, then we won't get better at learning and implementing better in the future.
Thanks, Vicky. Thanks, everyone. I think we have done an excellent discussion. Back to you, Andy, for the wrap up.
Wonderful. Thank you, Alex. Thank you, Victoria. Thank you, Sura. And thank you, Brooke. It's been super interesting, a lot of information shared, a lot of discussion. I'm going to spend 1 minute to a few lessons pulled out from today. First, it's very clear that BMS programming, it cannot be one-size-fits-all programming. It has to be context-specific. That it's super important to have good counseling skills to address mothers' needs and their preferences. That while we've had different experiences between Haiti and Jordan, in general, we know that there has to be good linkages with multi-sectoral programming, for example, wash, supply, logistics, likely mental health, like psychosocial support. But the one thing I really want to emphasize is that we can reach scale, and that we have to have the willingness to do so, and we have to overcome those obstacles and figure out what those obstacles are to actually doing it. In summary, today is the last webinar in the series. So I'm just going to wrap up with one last sentence about relactation, wet nursing, shared nursing, whatever you want to call it, BMS programming. Let's not leave these children and mothers as an afterthought. We need to make this systematic. We can't come upon a case and say, what do we do? It's going to be too late for that child. So let's try to see how we can move forward this type of programming. I think there's a lot of willingness. It's been shown by how many people have been interested in this webinar series alone. So I want to thank you all for your participation today and in the other webinars if you've been able to join us. If you haven't, they are on the TechRRT website. I will be sharing the link. We will be sharing it by email with everybody who's registered, but in the meantime, you can go to the TechRRT website, to the resources page, webinars, and find at least the 2 that we've already done. But we do ask that you fill out the webinar evaluation form. It will only take you 2-3 minutes, and it's very much appreciated. It gives you an ability to tell us what you'd like to see in the future. We will share the recording and the slides, as I said. Also, if you have questions that were not answered, please do feel free to add them to our website or drop us an email, and we will figure out how to answer your questions. With that, I want to thank our presenters today, and Alex, and Save the Children in general, and Linda, and the Feeding and Emergencies Core Group in general, for all the hard work, as well as the other people who've been involved, Maya and many others who've been the presenters from the whole series. And thank you so much for the hard work, and I think it really has been worthwhile. So we'd love to hear from you on that evaluation. Thank you, and enjoy the rest of your day, or your whole day if it's just starting. Thank you.
Lo dico,